Dear friends and colleagues, respected chairpersons, moderators and panel of discussion, it's my honor and privilege to be here with you. I think I am the last person. So, coronary artery aneurysm to treat or not to treat. Actually, 45 years male patient, chronic coronary syndrome patient, actually treated CT/RCA. I just show you the slide. Treated and discharged. I just show the case very fast. Very fast. It is, if you look, that was treated and discharged with DAPT, but the story started. Patient improved symptom and discharged, but after 1 month, patient facing difficulties lying flat and radiate to pain in the pain and fever on and off. He consulted in the divisional headquarters and found troponin is evidence of troponin leakage, and ESR is mild to moderately high and total count is very high. And it was the ECG, and they underwent cath lab and did angiogram and found left system is okay. Right system is, if you look at this, there is an aneurysm. So they sent it to in our Dhaka NSABD, and we take over it and we discuss with our surgeon team, please go for surgery. They proposed, as because it seems to be infective cause, so surgery as well is much more dangerous than intervention, so you can proceed. So as we proceeded, just control of infection, and we just proceed and just take a shot. You see the aneurysm, what actually in divisional headquarters right now, it is much more bigger than the previous one. So what we did, we down the wire as soon as possible. Then we go for pre-dilatation, and then we go for just to make sure the lumen. Then we go for covered stent, and we did it. But we need to cover it by 2 overlap covered stent, and finally we fix it. If you look at this, still there is a residual dye shadow, you can see it. Then again we go for post-dilatation at 20 atmospheric pressure. And then this is the final result. It seems to be sealed. This is final result. So we follow up after 4 weeks, and that's immediately after procedure. The echo shows there is a large still aneurysm is there. If you look at this CT after 4 weeks, there is a very large size still in 6.3 into 5 centimeter, and CT angiogram shows coronary artery is okay. There is a sealed, the aneurysm wall was sealed, and there is some residual RBC as well as the thrombotic process try to absorb day by day, and it's changed into fibrotic changes and index hospitalization. Where is the slide? So patient, after doing the procedure, patient developed hemoptysis the following day. Then we stopped the ticagrelor. Then patient was improved after discharge 18 days, but we planned for again MRI. MRI also shows size is much more reduced. Also there is a evidence of aneurysm. It is size is shrinkage, and this is the, if you look at this, and again 4 weeks later we just follow up by echo. If you look at this, size is gradually reducing, and if you look at the extreme right panel, previous echo, huge size, after 4 weeks, you just 1/3 size is reduced already. So again 4 weeks, we just go for CT angiogram again. Now it is size is become 3.3 into 1.2. Then we just follow up the patient, and we just schedule for this next year, go for CT angiogram again. But what I am telling you, coronary aneurysm is really, incidence is 0.3 to 0.5% undergoing CAG, giant aneurysm having a prevalence of 0.02 to 2%, but common in RCA, followed by LAD around 32% cases. Involvement of 3 vessels of left vein is rare, but most aneurysm are in fact pseudoaneurysm rather than a true aneurysm. So management of aneurysm is dilatation of coronary vessel is challenging. Most of the recommendation mostly based on anecdotal data, but how we treat, how should I treat, how could I treat, how did I treat, I just showed you the risk of thrombosis, rupture and chest pain is the main concern in mind to decide for the next strategy. And heart team approach is ideal to manage, especially in giant aneurysm cases. So I think in aneurysm, what should I do? What is my belief? Something is better than anything. Anything is better than nothing. So thank you. I should stop here.